A very warm welcome to everybody to today's webinar and panel discussion. I hope everybody is able to hear us. If no, please type in on your chat so that we can immediately rectify the technical issues. And if you have any queries in the process of the panel discussion, we request you to type in all your questions on chat. And we would be able to take in those questions. Thank you for confirming some of those who have confirmed that they can hear. To start off this panel discussion on the guidelines on telepsychiatric social work, I'll first request our head of the department, Dr. Dhanshekhan Pandian, to give the welcome address and give a brief about the guidelines for telepsychiatric social work, which were released on May 31st. Dr. Pandey.
Good morning. Namaskar. It's really a great opportunity to meet all of you on this occasion and share the experiences of the guidelines for telepsychiatric social work practice from the Department of Psychiatric Social Work, NIMHANS, Bangalore. I am extremely privileged and honored to invite all the members who are participating today in this very important meeting. I am extremely happy to welcome Professor Dr. K. Shekhar, Professor of Social Work and Registrar of NIMHANS, Bangalore. I am extremely proud to invite Professor A. Tirumurthy, Professor, Department of Psychiatric Social Work, Dr. N. Janardana, Additional Professor of Psychiatric Social Work, Dr. M. N. Brinda, Associate Professor of Psychiatric Social Work, Dr. Arthi Jagannathan, Associate Professor of Psychiatric Social Work, Dr. T.R. Kanmani, Assistant Professor of Psychiatric Social Work, and my other colleagues from the Department of Psychiatric Social Work, Professor L.S. Gandhidas, President of the India Network of Professional Social Workers Association, Bangalore, Professor Suresh Badamath, Professor of Psychiatry and Chief of Telemedicine Unit of NIMHANS, and Chief of Forensic Psychiatry and various other services, who is a collaborator and who was instrumental for the development of this psychiatric social work guidelines. I am also extremely happy to welcome many other external members who have given their expertise by virtue of reviewing the draft. First of all the faculty members from my own department, Dr. Surinder Jaswal, Professor and Deputy Director of Tata Institute of Social Sciences, Mumbai, Professor Sanjay Bhatt from Department of Social Work, University of Delhi, Dr. Kalpana Sardi, Professor and Deputy Director, Tata Institute of Social Sciences, Guwahati Campus, Assam, Professor Amila Segar, former Dean of Social Sciences, Rosengalaya, Mangalore, Professor P. Ilango, Professor Bharatidasan University, Tirunelveli, Sri M.B. Sri Ganesh, Secretary General, India Network of Professional Social Work Association, and who has been elected as the Regional Vice President for the Asia Pacific Social Work Organization in the International Federation of Social Workers, Dr. Anis K.R., Vice President, Kerala Association of Professional Social Workers from Kerala, Professor Sonia Pereira Theory, Professor Head Department of Psychiatric Social Work, Tejpur, Assam, Dr. Subhasis Patra, Associate Professor, Central University of Rajasthan, Dr. Praveen Yanavar, Psychiatric Social Worker, Department of Psychiatric Social Work, IBAS, New Delhi, Mrs. Veeralakshmi, Dr. Nancy Prem Kumar, Medical Social Worker, Jipmar Puducherry, and many other senior social work professionals from all over the country and all over the world for extending all their unconditional support to the department for the successful development of this guidelines for telepsychiatric social work practice. As we all know, the National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore, has a very important status not only in the country but all over the world for focusing on all aspects of physical and psychosocial well-being with providing a higher quality of services in the field of health and mental health. Department of Psychiatric Social Work is an integral part of this multidisciplinary team and taking lead in providing a meaningful psychosocial services for the people who are in need, and also conducting various manpower development in the field of psychiatric social work and in mental health, and also have higher quality research in the field of mental health and neurosciences. And we also involved with various capacity building activities for the country. As the government of India is committed to providing equal access to quality care to all members, the Department of Psychiatric Social Work has developed this telepsychiatric social work in mental health system, as we all strongly believe that such kind of development will reduce the barrier to access care and improve continuum of care services for people who are in need. And India's digital health policy advocates the use of digital tools for improving the efficacy and outcome of the healthcare system and lays significant focus on the use of teleservices. The Department of Psychiatric Social Work in NIMHANS, we have committed to develop this telepsychiatric social work guidelines so that people who are in need can make use of the services from all over the country. The Department of Psychiatric Social Work, we have successfully completed the guidelines for practicing telepsychiatric social work services, and which we have used practically with the different sections of population that we will be discussing in the later part. As we all know, the Department of Psychiatric Social Work Services were initiated at NIMHANS in 1963. Since then, the department has been providing preventive, promotive, and curative health and mental health services for different sections of the population of the country. The department is also well known to be a pioneer in conducting various collaborative research activities in both national and international agencies, and has taken a leading role in conducting many capacity building programs on pertinent psychosocial issues. The department also has initiated many networking and collaborative activities with various national and international organizations in providing a higher quality of psychosocial care and support services for the marginalized, victims of trauma, discrimination, and people in distress. Keeping in view of the recent technological advancements in the country and the Digital India vision by the Honorable Prime Minister of India, Sri Narendra Modi ji, the Department of Psychiatric Social Work has initiated numerous clinical intervention services from in-person to telepsychiatric social work practices. In this regard, the Department of Psychiatric Social Work has also come out with the development of this telepsychiatric social work guidelines for providing various clinical training, research, and allied services using modern technology to reach out the larger number of service users in the recent global crisis of COVID-19 pandemic. In this context, it is imperative to have a clear set of guidelines for psychiatric social practice using technology and to ensure the continuity of clinical services without any compromise on the quality, ethics, and standards of practice. The Department of Psychiatric Social Work would also train the professional social workers across the country for extending the tele-social work services using the modern technology. So it gives me an immense pleasure to bring out these guidelines of telepsychiatric social work practice, which is the need of the hour. I strongly believe these guidelines will be of tremendous use for the psychiatric social work fraternity from all over the country to extend their services using technology, especially for the marginalized and needy people in their own communities. I also strongly believe that the present guidelines would provide a conceptual framework for professional social workers working for the empowerment of individuals, families, groups, communities in order to improve their overall quality of life. So today's panel discussion will primarily focus on the practice of this telepsychiatric social guidelines. Earlier, we have released the draft guidelines and we got many feedback and suggestions from various members from the professional social work academicians, researchers, trainers, and practitioners. we have incorporated the suggestions as discussed by our team. And today we are going to have the practice, particularly with the individuals, with the families, with crisis, people who are under crisis, and also in the area of capacity building in the area of psychiatric social practice. So with these few words, I once again welcome all the members for your valuable presence today. And I'm extremely happy and thankful on behalf of the department for your valuable time. I strongly hope that that effort will be provide a kind of a higher quality of services for the people who are in need. I sincerely welcome once again all of you. Thank you very much.
Thank you so much, Dr. Pandian. As Dr. Pandian mentioned, today we are having a panel discussion to discuss and share the experiences that some of the consultants have gone through in using the Tele Psychiatric Social Work practice guidelines. And we have 4 panelists today. The first panelist is Dr. A. Tirumurthy, who is the former head of the Department of Psychiatric Social Work and who's also been one of the core team members in drafting these guidelines. The second panelist is Dr. N. Janardhana, additional professor in the Department of Psychiatric Social Work, who would be sharing his perspectives of working with family using the guidelines of telepsychiatric social work. The third panelist is Dr. Vrinda MN, associate professor in the Department of Psychiatric Social Work, who would be presenting her points of view and her experience in working with individuals using the telepsychiatric social work guidelines. And the fourth panelist is Dr. Kanmani, who is an assistant professor in the Department of Psychiatric Social Work and would be presenting her experiences of using the telepsychiatric social work guidelines in crisis situations, as Madam has been working extensively in the area of neurosurgery. I move on to the panelists, and my first question to them would be to share their experiences about how they implemented the telepsychiatric social work guidelines for individuals, families, in crisis situations and in capacity building. So I'd first go on to Dr. Vrinda, and I would request Dr. Vrinda to share her experience and tell us how she used the telepsychiatric social work guidelines in working with individuals. Dr. Vrinda. Just a minute, Dr. Vrinda, I think we need to unmute you. Have you unmuted yourself, please? Just give me a minute. Yeah, please go ahead. We can hear you, Dr. Vrinda. Thank you.
Thank you, Arati, for your brief introduction. As mentioned, I am briefly going to share my experiences of a case which sought the consultation through telepsychiatric social work. Briefly, I am going to present the background of case and what I have done in order to help her out. So this is 35 years old D, female, completed graduation, homemaker, married, having 2 children, referred by NIMHANS COVID-19 mental health helpline for addressing psychosocial distress secondary to domestic violence by her husband. She has been married for 8 years. It was love marriage without the consent of family members from both the side. Husband is a graduate working as an accountant in a private firm in Bangalore. They have been living together as a couple in a rented house in Bangalore. Though they are living as a couple, the client reported that the husband has not informed about their marriage to his parents and other family members due to intercaste marriage. Client reports that the first few months of their relationship was good, and gradually she noticed that husband started to control her by trying to find fault in her behavior. Client reports that she has been undergoing domestic violence from last 6 to 7 years, and frequency of the violence has been increased from last to 3 to 4 years. Client reports that the current reasons for seeking help was that the 3 months back husband got married to another woman without her knowledge, and she got to know about this information through her friends about his second marriage. following his second marriage, he stopped caring her and her children, and he would visit her once a week and abuses her and threatens her to leave her and children if she complains of her second marriage to a police or a neighbors. So he would send her threatening messages whenever she tries to reach him out and threatens to leave her forever. So when the client called, the reasons for some of consultations were she was unable to sleep and unable to concentrate on day-to-day activity, unable to cope up with the abusive behavior of her husband, and worried about her future and future of herself and her children, and want to overcome the tension secondary to the ongoing violence and marital issues, and need help from us in order to make appropriate decisions about where to go, whom to approach. So the the following some of the procedures we have adopted. When the client called, the following procedures were followed. We collected the basic social demographic details of the client, and the client identification details were verified, and we also obtained oral consent from the client, and briefly collected about informations about the ongoing marital issues. And while collecting the informations, the therapist assured on the safety of the client by checking whether the abusive spouse was around. I think this was one of the things that we kept in mind, that since we know that the disclosure of the violence itself that may lead to escalations of the violence if the partner get to know. So when we are having a telephonic sessions with her, I have ensured that that whether the partner is around, so that she can speak about what is happening in her relationship, and also that she can communicate through certain code word, or she can stop talking to us, and later we can continue the session, and she can switch over and talk some neutral topic if the partner comes get to know about her, if he's around when she was talking to me. This aspect was taken into consideration while offering telephone counseling. And also I have collected through this session that what are the support that she is having, and what are the things that she has done in the past in order to prevent the violence, so that I get to know that her help seeking behavior and the social support she is having, so that that can be strengthened for the current issues. And also assessed what are her immediate needs, since he has got married to another lady without informing her, and not coming and visiting her very regularly. He comes once in a week for her and spends some time and give little money for maintenance, and not bothered about her financial aspect also and other basic needs. So in the process of collecting the informations, given a priority for what are her needs, current needs and the concerns, so that that immediate needs can be addressed. And also briefly evaluated her about her mental health status also, since she complained about not able to concentrate on her day-to-day activity and feeling sad, whether she fits needed any further psychiatric interventions, keeping in that view. So briefly assessed about her mental health status also, and also briefly about the ongoing trauma, and also if there is any danger or a threat for herself and her children. That was briefly evaluated during the session itself. Um, and and also allowed her to express her feeling, and offered an immediate emotional first aid to her. That was the need of the hour, because when she called to us, she was in a distress, that she wanted to ventilate what is happening to her, and also to know that somebody believes in her stories. So in the process itself, that as a therapist, we allowed her to ventilate her distress, and conveyed her that the support is available, and she is not alone in this difficult process. That was communicated to her throughout the sessions, and reassurance was provided to her. And also, and keeping in view of ongoing violence, especially a psychological, and there were reporting of threat to her children and herself. Keeping in that view, we have ensured of safety of the women by giving her informations about where to go in times of crisis, the helpline centers that are available in her nearby locality, and the contact detail of the police number, and also a domestic violence protection officers numbers also been provided to her in case of crisis, so that she can reach to us and take their help. This is the thing that was ensured during the process of intervention, and this session continued for 2 to 3. We continued 2 to 3 sessions with her, and this was the things that we have done when the client called to us.
Thank you so much, Dr. Brinda, for giving us an overview of how you worked using the tele mode with a client facing domestic violence. If anybody has any questions, please type it on chat and we shall take it up towards the end of the panel discussion. I now invite Dr. N. Janardana to share his experiences of working with families using the tele-psychiatric social work mode. Dr. N. Janardana.
Thank you, Arti, and good morning, friends. So today I'm going to share about my experience of using telepsychiatric social work guidelines in providing family intervention. So recently I met a 37-year-old male and his wife 36-year-old approached family therapy. And the personal identification details and intake session was done during in the family therapy ward itself. And later we were not able to continue the session because of the lockdown. And as part of tele follow-up with our clients, so we gave an option of initiating the telepsychiatric social work services through telephone. And husband was happy to be part of, to take up such intervention. And he gave consent, and he also, an appointment was fixed. But he didn't have consent with the wife. So I requested husband to put the phone on speaker during our appointment day, and then the consent was obtained from the wife. Wife also agreed to be part of telepsychiatric social work services to receive such services, and then we planned our intervention. So we made some preparations in terms of we had requested the couple to make some arrangement for children, so the children would not be disturbing during the session, and they can have some privacy in a room. And some activities were given to children, and they were kept busy. Then we started having a session in the privacy. We started the session. So before the session, we started establish the respectful and empathetic working relationship with the couple. And during the session, consent was again obtained from the wife and informed that the session cannot be recorded and used as an evidence in future. And session can or may be disrupted due to technological errors, which was informed to them, and their contact details were given again to them so that they can contact us back. In case if they are not re-established the contact within 10 minutes, then that session would be terminated, and we would get back during the next appointment. So this was all agreed during the session. So what I understood during the intake session was the couple have been married since last 12 years. And couple met in their own office, and it was a choice come arranged marriage. Husband had convinced his parents about this marriage, and whereas wife was not able to convince her parents, and then they got married without the consent of wife's family. So soon after the marriage, a couple left to Germany, where they worked for 5 years, and then they returned back to India. And then when they returned back, they stayed in wife's house for a period of 1 month. During that stay, husband felt that he has not been respected and the children are not been cared. And then immediately he picked up a fight in that family, and then they have to migrate from Hyderabad to Bangalore, where the husband's place. And then they re-established their own house. And since then, there have been a strained relationship with the in-laws. Husband doesn't like to visit in-laws, but at the same time, he doesn't restrict wife to maintain any contact with her siblings or with her parents. But wife made a decision not to be in contact with with her parents and siblings. And since last 5 years, the couple, wife has not spoken to either her siblings or her parents. And during this period, her father expired, and she attended all the ceremonies but could not continue the relationship. And it was her choice not to have relationship. Like what the couple reported during the assessment was first few years of their marriage was a happy marriage, and they did not have any issues. And once they returned back to India and then settled in Bangalore, some problems started within the couple. So husband feels that always a wife complains of headache and not able to complete the task, and she is not able to provide care for children, and that's the reason for their fights between the couple. Whereas wife would talk about the husband not being giving the respect what she deserves, and she feels loneliness because no one is there to support her, and she cannot share even her feelings. She is not able to find any friend where she can vent out. And similarly, like she's not getting support. Neither the husband would listen, and husband would raises his voice, and which makes her to be lonely. So this was the problem presented during the intake, and we started exploring during the tele session. And tele session, we started doing the assessment and intervention together. So till now, we have seen the couple for 3 times. So what I understood during the assessment is that there has been a good role allocation within the family, where husband been very supportive in terms of household chores, because wife doesn't like to have a maid in terms of getting a help for domestic work, and husband as compensating this work, and role allocation is good within the family. Whereas the noise level in the family is always high, and there is no quality time between the couple or within the family members. So this is something we felt we need to strengthen. So we started collecting information about family developmental stages, and still in the process of collecting all the information. At the same time, we started providing intervention in terms of enhancing the quality time between the couple and with the children, so that each one would like spending time with each other. So which has been initiated, and a couple are following those things. And still we need to work in terms of strengthening the relationship of this family with their extended families, and then to draw a boundary between the extended family. And also there is a need for strengthening communication within the couple, so which we are working out. We have given some tasks to them, and still some role plays need to be played, which we are going to take it as the future plan. So we are also planning a lot of indoor activities because of lockdown and restriction in terms of social movement. So indoor activities need to be introduced, and couple also need to have some indoor activities in terms of for their own between them and with the children. So this is something we planned during the last 3 sessions, and I'm still in continuing with them. So today morning I had a doubt whether I have consent in terms of presenting their case in a public platform. So I have to make a call today morning and got their consent, and now I'm presenting. And I have not identified the client's detail except their age, so that the confidentiality is being maintained.
Thank you, Dr. Janardhan, who's given a detail about over the last 3 sessions, how a detailed family assessment could be feasible using the Tele PSW guidelines, and also about how initial goal planning could be implemented in a family therapy session. It would be interesting in the discussion later on to understand how certain other activities could be done, like role plays in a family therapy session using the telemon. We have Dr. K. Shekhar, our senior professor from the Department of Psychiatric Social Work and Registrar of NIMHANS, who's been extremely supportive of this entire activity with us today. I would request Dr. Shekhar to please give his comments about the usefulness of these guidelines and how they can be implemented at the larger macro level. Dr. Shekhar, please. So we'll need to unmute. Yes, you can go ahead, sir.
Permission. Thank you, Aarti, for that kind words. And Dr. Tirumurthy, who is moderating. I'm really sorry, I should have come subsequent to that of the crisis intervention, but having to manage some other crisis, I had to request the head of the department, Dr. Pandian, whether I could just have a few remarks rather than coming in the concluding session after Dr. Gandhidas. Congratulations to the Department of Psychiatric Social Work for having organized this particular webinar in terms of their tele-psychiatric thing. Before that, probably a month back, they have added a jewel to the crown in terms of releasing the document on the tele-psychiatric consultation guidelines for tele-psychiatric social work practice. Looking back, way back from a custodial care to the other type of a care 4 to 5 decades back, when we started some community mental health movement, people were talking why to reach to a community. But today a situation has come wherein in a situation of pandemic, which is causing a large amount of threats and threats to the entire service provision, reaching to the unreached is becoming a major issue. In this particular tele line comes to a larger sort of a help for reason starting from 29th of March till date. I personally had been able to, with a larger team and a larger network of institutions and other things, I've been able to cover up almost about 3.2 lakh people, a virtual sort of a OPD on a tele helpline, which addressed most of the psychosocial as well as the mental health service needs of the people around. And we could see a large amount of changes in the patterns which were coming as in when this helpline was launched. And at this point of a time, when the department took over, after a primary level of screening and trying to give back to the consultants certain cases, I do remember the challenges what came into picture. The challenges were in terms of not only dealing with just a single individual's issue, but also the family issue, distantly placed family issues, and geographically wide apart families, and then coming over to crisis situation that the particular person or a aged person or a child or adult undergoing certain problems, how do I intervene? How do I come into a crisis situation like a suicide? When these issues came up, in a at point of a time, they came up with this particular guidelines. And this is creating to make a major change because a threat was converted into an opportunity currently by the department. And they are also giving you the example which we might need to take forward to see how we can go about it. And at the macro level, in terms of the government is concerned today more than the biological or the other aspects of it, the economical aspects of the pandemic, the psychosocial and mental health is standing much, much forward. So while doing that, is there a systematic way to go about it? A decade back when this, I was hearing in the international forum and all, there was a large amount of issue asking about evidence-based issues. There were issues pertaining to how can you elicit the emotion by a telephone. You are not able to see the subjective and you are not able to come out to an objective decision on the mood of the person and all. These are all the professional challenges what we have when we talk about, or the question of how are you going to empathize when you're not able to look at the particular person. So the job of us technically, professionally becomes much, much higher when we look at these sort of issues. And I do appreciate some of the case studies which were presented by Vrinda as well as Janardhan, which should also give us that while doing a psychiatric social work, it is not only the need to know the technology by the professional themselves, but also bring it to such an extent how it could be reached out like a simple TikTok, what a rural person is able to use it, though it's a banned sort of a thing. How this app we could be able to make our client to approach us, and also the very fundamental thing which Janardhan was mentioning, that I took the concern of the person in terms of maintaining the confidentiality, as well as while sharing in a meeting like this, how are we able to draw out certain ethical framework of the psychiatric social work thing. Furthermore, I would like to importantly say you, there are two other aspects to it when we look at it from a larger perspective, that all these sort of issues are also associated with certain uh, legal issues. So one needs to be more careful on the legal issues, because these sort of things could be just taken as a document for varied purposes, which could harm the basic social unity what we want to bring in with by an individual who has a mental health issue, or between two members in a family, or in the larger community. So friends, while maintaining certain records of this, be known that any digital record created can always be also be accessed by certain other persons. Take utmost precautions in keeping both the electronic resources in a manner which you could safeguard it by having an access key, and maintain the boundaries during the tele sessions. Don't go little out of the boundary, because here things which are said cannot be erased back just because you said, and later you should not be coming out of the thing. We can use various medias, website or online social networking and other electronic communications to mobilize and organize communities and advocate policy issues in appropriate platforms. But be careful on what you're uttering and what you're talking about it, because that has a larger value to an institution what you're working for. By this particular tele-psychiatric social work program, I'm sure that we should be able to have the last mileage coverage, and one of the very basic component of mental health at a national policy level, you'll be making availability, accessibility, affordability at a very, very low cost. And last, when I said about the cost, it takes away large amount of a direct cost, indirect cost, and the intangible cost what a family would have invested compared to an institution. Institutions can always bear up some of the direct cost of it, whereas the help what you are rendering to the family is of the utmost importance. And let the department show as a flagship program how we would be able to run virtual OPD services as well as psychosocial support services of a micro or a meso or a meta sort of a level of communicating to that of the clients or the persons with different areas of work. And the last but not the least, rehabilitation is one of the issue what we also need to take into consideration, because a large chunk of the work of ours will come into that force. In that, how we could be supportive both to the families as well as to the patient of utilizing certain internal resources in and around them, as well as in the local community. The challenges are many for us, and let us look forward to work together and take this entity much forward. Thank you very much. All the best.
Thank you so much, Dr. Shekhar, and I'd like to thank him for joining in this panel discussion amidst his difficult schedule today. Thank you so much, and I suppose you will have to move for another meeting, sir. Thank you for joining us, and we hope if you finish early, you can join back us again. Thank you. We'll now continue with the panel discussion, and I will move on to Dr. Kanmani, who will share her experience of working in a crisis situation with a client and let us know how the PSW guidelines were used in such a case. Dr. Kanmani, please.
Yeah, good morning to all the professional colleagues. Today, in this platform, we are going to talk about how this guidelines is going to help us in providing crisis intervention. So this guidelines, as it was being told by Professor Shekhar sir and with my other colleagues who have presented, it is basically during this COVID-19, we thought of bringing up with this guideline because we had faced quite a lot of challenges, and we also felt a lot of things which was really good. So we, keeping this in mind, we have developed this program. So now when you look at crisis, as all of us know, crisis basically occurs within immediate or acute situations, and it is basically expressed with behavioral difficulties, emotional and psychiatric response triggered by any of the precipitating factors. So when we have to provide a tele crisis intervention, there are a few things which we need to definitely keep it in mind, and we also set a goal when we are starting with any cases. There are a few goals which I have set up with the case which I'm going to discuss with you guys are ensure the safety and an emotional stability of the person which I have kept in mind who's been experiencing an emotional crisis or any mental illness, which mild mental illness. And there were few things which I thought in my mind was any deterioration which happens because of the acute crisis, and they have a few mental health status. And I also kept in mind when I was dealing this case to avoid a development or an enhancement of more effective coping skills and also the support system which I try to tap. And I have actually thought about help in obtaining ongoing care for the emotional crisis and whatever difficulties they had. So with this brief introduction, I just would like to share my experience after this COVID pandemic, the case which was referred to me by the institute. What they have asked me to deal with few things with the family members, because patient was already admitted with us in the neurosurgery setting, and patient was in a acute health difficulties, and there were no support system which the patient had. He was a very young boy, 22-year-old, and there were friends who were living with him, and he was working for a major industry, IT industry. And his friends were also very young, of 22-year-old, where his parents were living in North India and very far away, almost around 16 hours journey, and there were flights and everything have been cancelled at that time. Transportation was a real tough time, and this was an initial lockdown when it started. The case had come over there, and patient started crying, and he was unconscious, and friends were extremely scared, and the institute, the what do you say, this patient who worked in the industry, the HR division had taken the responsibility. In turn, the institute had asked me to coordinate with the HR and with the family members. So now there were two dilemmas I had, because HRs are usually wanting their, what do you say, the patient to get recovered. So they were all, it was new for them also. And at the same time, the family members who were staying in North India, it was one, feasibility is only through telephone. The father did not have a facility of having any WhatsApp calls or even video conferencing. It was very difficult, and network was a very extremely challenging condition. He was from little remote area, but when I called them up, immediately they had a lot of emotional crisis. They started crying over the phone because they didn't know how the son is, because the friends were talking and they were telling many things, whatever treating team was telling, they were trying to convey that, which wasn't which would have given them actually an emotional instability. And mother was extremely panicked, and father had a lot of fear because he was the only son. So then when I taken up, the initial thing, what I have provided was, like, I have taken all the basic informations from them, because I couldn't immediately take consent. So because it was extremely an emotional difficulties what they had. So initially I addressed that by providing a psychological first aid. Then I started with informed consent form and assess the situation what they have been having it. And after that, then I have connected them with the treating unit. The father had a discussion because mother had a language barrier. So the father had actually translated when we were doing a telephone session. The father had translated and then tried to try to make the mother to feel very comfortable about the son's condition. Okay, so this went on around 13 days, and now and then I had an acute father had acute crisis, emotional difficulties, mother also overwhelmed with the emotional disturbances. So then every now and then I started having a call, and then we have given them all informations over and over again. We have ensured and reassured all this, which we have done over the phone. And we have also helped them to talk to the ministry by providing all the details, what they basically need to get permission and travel. So after 13 days of managing now and then the crisis situations, parents had arrived. So this was the case which we have faced. It is not only one case with the crisis intervention what we have provided. There were multiple cases, but this was one case interstate over the phone without any except the phone. There were no other mode where we can have a conversation. Especially a video conferencing would have brought down the crisis little more down, which I felt with the thing. So there were few things which I felt of doing this crisis intervention through the phone. The advantage basically was we could able to provide an immediate psychological first aid. We could able to follow ICF and all the other things. And emotional support we have provided, and also able to assess the situation and act accordingly. And also, like, there were few things which I have felt with, particularly to this case, was like dealing with the employer and dealing with the parents and dealing with our own setting. So that was the more challenge which we had. And then we have tried to sort out whenever the crisis have raised, we could able to provide intervention following all the guidelines kept in the mind, and we have provided. So with this, I would like to conclude the crisis intervention is feasible by following guidelines of the telepsychiatric social work. Thank you. Thank you, Arti.
Thank you so much, Dr. Kanmani, for giving a succinct response about how, in a crisis situation, psychosocial interventions were done with the family. We now move on to psychiatric social work practice for the community, especially in capacity building. A number of telepsychiatric social work interventions are to do with capacity building and training of trainers. And Dr. Trimurthy, our former head, has been involved in a couple of capacity building initiatives in the last couple of months after the pandemic broke out. And I would now request Sir to tell about his experience of doing an online capacity building training program and the components of the same. Dr. Trimurthy.
Very good morning to all of you. Thank you, Arti, for your nice introduction. And we all should be very happy that today, as a professional social worker, we are going to launch out an innovative telepsychiatric social work services to reach out largest population the country needed psychosocial interventions. Before me, there are 4 speakers have shared their experiences about how to address mental health issues of family who has problem, a woman couple has problems, and how the medical crisis can be addressed in an emergency situations. See, here I would like to share my own experience, how we are handling telepsychiatric social work services in the areas of geriatric mental health. I thank the opportunity given by our head of the department, Professor Pandian, to collate all these services in different sections and given an opportunity to share with you. And this is the thing that much before starting the telepsychiatric social work services in NIMANS, we have been part of doing these services for geriatric mental health services. And what we were doing it in order to help individual, family, groups, and community, we have identified patients who need comprehensive psychosocial intervention services when they come to NIMANS for inpatient services. Then onwards, we will make them registry and we will call them and we will intimate them. These are the telephonic services also available as part of geriatric mental health services. It is again a services of multidisciplinary team which caters to the needs of different needs of geriatric population. It may be for general well-being about elderly. It may be for persons with the dementia and their caregivers. And also, we are providing a certificate course on promotion of well-being among senior citizens. These are the three areas on which we are providing a comprehensive kind of services. See, what we do, the multidisciplinary team who takes care of the patients at OPD level will get a contact, all those numbers, details, identifications, and we will ask them to register in case they had a difficulty in contacting us. In case they want to contact over telephone, we will be able to address their needs, concerns, and sometimes it may be a simple medical management where we will be helping them to take care of the medical management part. So likewise, not only we are addressing the issues of individual, but also the caregivers. The caregivers who has been giving care to the persons of elderly or persons with the dementia might undergo different kinds of challenges in terms of experiencing their own mental health issues, their burden, their adjusting their daily routine or schedule, um, life challenges. All those things becomes a matters and concerns for them. So for that, uh, we have a care group online support program in order to better care, better management for persons with the dementia. We know that dementia is a major neurological conditions where the person will have lots of memory difficulties and behavioral disturbances, all those things. By giving them long-term care, they become kind of um, uh, difficult, and they also undergo lots of emotional turmoil, challenges, anxiety, and depression. So for them, we will give a special session on how to enhance their competencies in terms of dealing with their day-to-day affairs, stress management, how to use better coping strategies, how to have better problem-solving skills. It is a comprehensive stress management strategy so that as they keep giving a kind of services to them, in some point of time they will become a kind of resilience where they can have any kind of challenges in the future or any kind of situation where they will become a better trained person to handle the crisis situations. So that is what we basically train people who are having dementia, the caregivers who are handling or the giving the care to the persons with the dementia, all those things. See, this is a challenge where since it is an telephonic consultation or online based, we train the caregivers or we train the personals or other stakeholders to prior register and give a trial run also. Sometimes how to use the apps, how to register, and we will make them participate effectively. See, we will give the Zoom ID and Zoom registration number, all those things. They can register and prior mock run also we will give so that they will be able to better log in, will not have any difficulties. So far, around almost 10 to 15 batches we were able to conduct, and we were able to contact every given point of time 30 to 40 participants they will be able to register. And 8 groups we have been so far successfully conducted in immense, and all of them having satisfied with our own services. And also the feedback given by them, Bangalore being such a kind of chaotic traffic conditions, they could able to access very well, and they could able to utilize our services in effective way. They satisfied and told that it became a cost effective, because if one has to come to the hospital, they have to leave out their job, they have to leave out the home assignments, all those things. By home or workplace itself, they can easily able to log in and obtain our services. So this is what we are doing it. And the topic will be on different kinds of aspects: basic understanding about the geriatric mental health, what is the dementia, how the challenges can be meet out, what are the coping skills that they need to have it, what are the problem solving skills they need to have it, basic stress management strategies, all those things we will cover. Similarly, we are also running a 3-month certificate courses along with my fellow colleagues, Dr. Surgeon Anthony, PT Kumar, and the entire psychiatric, geriatric psychiatric services. So far, we have conducted 2 batch of certificate courses in immense. Around 60 participants have been completed successfully. See, one of the participants is notably from our own former professor from the Department of Psychiatry, Dr. R. Srinivasa. He had also given a very nice feedback, and he also given some of the topics, the inputs to how we can include different topics and understanding the general well-being of the elderly, different policy issues, welfare programs, promotion of mental health among the elderly. All these things we were able to provide. And I am also happy that we have an effective team in coordinating these services of our own department. The PhD scholars, particularly Cecil Vasandra, Manjunath, Anu, all these people are effectively coordinating these online support programs and make it possible and reach out to the large section of the population in the community. I'm happy that I'm also growing older, and I'm also able to provide venturing out to the geriatric services and to concentrate and provide effective services in the years to come. And I'm very much thankful for our team for the coordinated effort in collating these informations on different topics. I'm sure this is going to be a flagship program for the country, that country which needed the large manpower pertinent to providing services to the different population who is need of emotional, psychological, and social help from. And NIMANS, particularly psychiatric social work, being the country's largest department, or the world largest department, we have faculty who is equipped in different skills and knowledge and practice, will be able to provide better services to help whosoever in need of help and reaching the population where unreached. Thank you. We will be taking up some of the questions in the last. Thank you.
Thank you, Dr. Tirumurthy. I think all the panelists have very eloquently spoken about how they have utilized psychiatric social work practice guidelines and implemented the same in their practice, either with individuals, families, in a crisis situation, or in training family caregivers. It would be interesting to know from them as to what are the challenges or what were the advantages of using telepsychiatric social work, though some of them were touched upon in the case presentations that they made. I'll move on to possibly ask Dr. Vrinda as to what were the challenges and the advantages, maybe both together, that she faced in providing telepsychiatric social work guidelines to an individual. Dr. Vrinda.
Thank you, Dr. Arati. Some of the advantages of practicing this psychiatric social work consultations from my experiences is that it provides clients to vent out their feelings and the emotional distress in a safer environment when it comes to domestic violence, in the absence of the partner, where she can vent out her feelings and also distress. Following that, it's possible for us to provide some of the preventive approaches in terms of planning for the safety management with the client, that what to be done during the violence explodes, and how to identify some of the red flag behavior of the perpetuator, so that she can plan well in advance uh, to prevent the escalation of the violence, and also if the violence occurs, what to be done, whom to contact, and we could able to provide a resources to her. And also many times we are aware that it's very hard for any person who is undergoing violence. It's very difficult to come in person and come in person for help. So this kind of in consultations help her in terms of maintaining confidentiality, also in terms of also in dealing with some of the stigma attached to seeking help, particularly when it comes to the helpline. It could be those kind of a stigma can also be dealt with, where women feel comfortable to address and also share what she has been undergoing. This provides an opportunity for her and also for the therapist also to address some of the distress that the person undergoing in a very non-judgmental way, and also convey her empathy, and also support her that she is not in the journey, and also provide a needed help that required for her, and also build her resiliency uh, to overcome and make better decisions to be in the relationship or not. This is something that one of the advantages of providing a telepsychiatric services uh, when it comes to the cases, especially domestic violence cases.
Dr. Rinda, could I request Dr. Janardhan to talk about the advantages in using telepsychiatric social work guidelines online while working with families?
Yeah, the main advantage is, as Professor Shekhar said, distance does not matter for us when we want to implement telepsychiatric social work services. And this is more suitable for metro cities where it's traffic and client need to spend a lot of time in terms of their travel, which can be avoided. The only requirement what we need to have is good technological gadgets and network which is required. And Government of India is working towards it as part of Digital India. So we can use such services and extend the telepsychiatric social work services through this means. We can either use audio or video. So as per the convenience and as per the availability in terms of the technology, it can be planned. So this is something I feel a way to reach out the last person. Because most of the time people are not coming to a mental health care setting. It's mainly because of the distance and the travel involved in reaching to a specialist. So that can be achieved through this. And also it's possible for us to give the expert opinion, which many a time is required, rather than just going to one a setup where such expert opinion is not there, and people being treated with painkillers, and rather than looking at the mental health need of the person. So by using this, expert opinion is possible for us to give, and this has a wider coverage which are more cost effective, so which can be replicated for the entire country, because most of the mental health resources are concentrated in the cities and metropolitan cities. So rural areas, we don't have facilities. And through this, it's possible for us to reach the wider community and the last person who requires us. And services can be extended through technology tools, which we have tried out. And we would request everyone to plan such interventions so that our services can be expandable, and people can receive the services at their doorsteps rather than expecting them to travel for a long distance in order to receive an expert opinion. So these are some of the advantages I felt by using telepsychiatric social work. It's possible for us to reach the wider community.
Thank you so much, Dr. Janardhan. Dr. Kanmani, would you want to add in any other advantages that you found in working with your family in a crisis situation?
Yeah. What I have found dealing with this case in the crisis situation was immediacy. What we mean by immediacy is immediate crisis intervention, which we can provide to the family who are in need. And one wonderful thing which I found from the Tele guidelines was a multidisciplinary team and referral services, which was done very well through this Tele psychiatric social work, followed all the guidelines, wherein even the multidisciplinary team members like a medical team, they have also followed the legal and ethical consideration, keeping in mind, and also followed the guidelines which we could able to tap and resolve the crisis situation. That was the one thing which I have found in this case, and also many other cases what we have dealt over this 3 months period. There was also one thing which I found: psychoeducation was definitely effective. Like I couldn't have anything to measure because I didn't think of that. Probably we can think of measuring the effectiveness of providing psychoeducation or providing psychosocial support or the information in the psychosocial first aid. What we provide, the information and the emotional support, which we also can think it over later in the guidelines part. Then the next aspect what I have found was client anonymity. That is basically they could able to, the family members could able to self-reveal whatever they wanted to without any hesitation, and also openness was present with this current case what I have shared, and also many other case what we have dealt in the mental health situation as well as the physical health situation, which we worked basically on psychosocial component. The other beautiful thing with the social work aspect in the crisis intervention, what I have found was they were good positive transference, which I could able to perceive that at the end of the session, which I have evaluated and also found over the phone with the family members. So these were the few advantages which I have felt was very good, and which can be definitely included over a period of time in the guidelines. And all the social workers, psychiatric social workers, medical social workers who are working in different setting, who wanted to adapt this tele psychiatric guidelines and using this tele platform will be really good, great, and they can initiate without any hesitation, provided they need to know in and out of what is what, and training which is definitely required in managing crisis. Thank you, Dr. Aarti. Dr. Aarti, I have completed.
I'm sorry, I started speaking without unmuting myself, one of the technological glitches, which we need to be careful about in providing telepsychiatric social work services. I'll now move on to possibly the challenges that the expert panel felt while delivering some of these services. So I'd first ask and request Dr. Tirumurthy, who spoke about the capacity building initiatives using the tele mode, to discuss about some of the challenges he felt he experienced while providing these services. Dr. Tirumurthy.
Actually, already the previous speakers have rightly pointed out different challenges. There are many challenges which we have foreseen in using these telepsychiatric social work services. The main challenge is here is that evaluation of skills learned becomes very difficult, because there is no parameter to measure what skills, how far, how much they were able to learn it. See, unlike in one-to-one sessions where we will be able to provide, we will be able to evaluate adequacy, efficacy, all those things. But in the online sessions, probably we are taking only the oral verbatim, how far, how much they are satisfied. We are not evaluating so far what are the we are evaluating the positive aspects only. The negative or the difficulties, the challenges which they faced generally are not reported here, because they tend to share the advantages than the disadvantages or difficulties. Hello. That The concentration, the another challenge is that as they keep listening for 1 hour, 2 hours continuously through audio telecapacity building program, it becomes a very difficult kind of thing, because they have to sustain their attention, they have to sustain their concentration, memory, different kinds of distractions. By all those things are very mattering for them to learn any kind of input which we are giving through the online platform. So when you give the same kind of thing in the classroom situations, it is very easy to sustain our attention span, or using our mental faculties in terms of attention, concentrations, memory, and other kind of things. Here you need to have focus. There are people would say that because of the technical difficulty, they will, they cannot sustain, they cannot focus on the particular areas, or it is not properly here, or sometimes it is unheard. They will use only the selective span of attention. So this is one of the other challenges which often we hear from the participants. See, we always believe that the effectiveness, cost effective, and the kind of benefits, both professionals, the service deliverers, and service receivers, in terms of utilizing the our any kind of services from telepsychiatric services, the participatory methods, where it becomes a kind of challenge. See, in the participatory methods, in the group of situation of homogeneous or heterogeneous, where it becomes a very, very important kind of thing. We can easily observe, we can easily evaluate, we can easily measure, and make them and give the feedback that how much they were able to, how much they were able to satisfy, how much they were able to get the input which they wanted. But here it's very difficult to use that kind of participatory methods, uh, uh, which becomes a difficult in online kind of telepsychiatric services. These are the common challenges. But other thing they say that except mm, physically coming to the place, and they all satisfy with the kind of services we provide through online, they can be available at their home or workplace. There is one person who was working in the WhatsApp, where times up, where while working itself we used to log in and attend the whatever the tele services we were providing. And
Brinda, if you could throw some light on the challenges that you experienced while working in the tele mode.
Some of the challenges that any session, if you take, whether in-person sessions or tele sessions, that one need to maintain the manage the time. So sometimes the crisis like this, or a situation like the DV cases that approaches to us, so it takes longer duration of sessions, and it even exhausts the therapist sometimes to listen attentively uh, uh, to the needs of the women. I think this is one of the challenges that affects the therapist. The other thing is that the crisis situation, like if the women expresses the ideas of suicide, or any DSH attempts in the past or present, so it's very in the context of ongoing stressors, it's very difficult for the therapist since the client is not physically available, to know that the severity of the distress that she is experiencing, also to make a detailed assessment about the lethality that she is having. So this is one of the things that one need to one of the challenges that one goes through. And apart from that, we know that uh, that when the women approaches, especially in the context of domestic violence, we know that she may not come for further sessions, or she may not reach out again. So during that context, it is very important for the therapist that in the helping process itself, that one has to ensure that we have provided sufficient informations to her, and also provided the resources that are available in the community, and also taken care of the safety of the women before winding up the sessions. So it is too much overwhelming for the therapist also to ensure all these aspect of that. Even if you take WHO guidelines, if it takes while working with the cases of the TB in healthcare system, the WHO guidelines itself says that when the women approaches that, whether it's a one session or a two sessions, you know that she may not come again for further interventions or a follow-up. It is very important for the therapist to ensure that the adequate informations, has been provided to her. So when the women made a choice to leave or to be in the relationship or not to be in the relationship, when she exercises her decisions or a choice, so that time she can take a call where to go. So it is important for us, keeping in that view also. Sometimes we tend to give all information to her, so the sessions may prolong for longer period of time. That may also taxing for the therapist, and therapist also will be overwhelmed during the session to help her out during the sessions. This is something challenges that teleconsultations that one goes through.
Thank you, Dr. Brinda, for summarizing the challenges so well working with individuals. I'd request Dr. Janardhan to pitch in to talk about the challenges that he faced in working with families in using the Tele Psychiatric Social Work model.
See, one of the biggest challenge what I've faced is I'm missing my clients now. So since 1 month, I've been involved in terms of providing tele-psychiatric social work using telephone or other modes. So I'm not able to meet the clients in face. This is something like I need to deal with myself. This is one of the biggest challenge because we are more comfortable providing intervention face to face. When we have to use technology tools in providing intervention, we feel a bit uncomfortable, which we need to deal. Over a period of time, we would learn those skills in terms of how to fine tune ourselves in order to meet the demand and meet the demand of the client's need. Another important challenge what I'm facing is non-verbal behaviors, which are more important as part of assessment and for therapeutic intervention, which I am not able to get it through an audio mode. Through a video mode, it is still possible for me to get the non-verbal communications, which would add on value in terms of assessment and then providing intervention. So this is another challenge we are going to face when we shift to psychiatric social work services. And it's also becoming difficult in terms of including co-therapists, because in all our family therapy session, co-therapists play a very important role in terms of giving each observation to the mind therapist, and so that mind therapist also would be able to reflect back with the co-therapist, which is not possible at this context. Still, it is possible in terms of having a conference call, but we have not tried out. This is something we want to try out and look at the possibility, and we may face some challenges in doing this. This is something we need to work on. There are going to be a lot of technological errors which are going to happen, so which we don't have control over it. This is something we need to work with the existing facility, and let us hope that such services are made available and kept available for all the people. We also need to have a good network with organizations in and around our place, because particularly when in my case, which was presented, the index patient had a migraine problem, and she need to attend for interventions, but they made their own arrangement. It would have been always good if the therapists have a good resource directory of at least services available in and around the place, so that the people can be referred by name, and a call can be made, so the services can reach, and our clients also would feel happy that the needs have been addressed. So these are some of the challenges I faced while practicing telepsychiatric social work since last 1.5 months now. Over to Aarti.
Thank you so much, Dr. Janardhan. Dr. Kanmani, would you want to add in any challenges that you faced in working in a crisis situation with your family?
Yes, Dr. Aarti. What I have found using this telepsychiatry providing crisis, what we need to keep in our mind is setting boundaries. It is not only in person, even in telepsychiatric social work, we need to set boundaries in terms of working with the employers, working with the family members, or working with client, all three together at a crisis situation when you need to deal a lot of expectations which comes from each individuals. So as a professionals, we need to set boundaries and make it very clear during the session or in the beginning of the session what can be done, what can be provided, what can be expected. So this need to be set, which I always I have learned with this past 3 months doing this tele psychiatric social work services. With that, I also felt like sometimes we tend to have a false assumptions from both the sides, like basically with the voice over the phone.
Either consent form or in terms of personal identification. So because client will be talking about their problem and which need to be listened first and allow the client to vent out their feeling. In the process, that procedural thing will get sidelined. Particularly, we have problem when the client started talking about either suicide or suicidal thoughts. Then immediately we need to caution the family member, other family member, other caretaker who can pitch in terms of safeguarding the client. If we don't have such information, if we are not collected at the beginning, then we'll get into trouble. So this is something often we find it difficult in terms of enforcing it, but we need to do it because this is something required in case of such emergencies, which need to be part of like which we have made as part of our tele psychiatric social work guidelines. But in the process of being helpful to the client and being therapeutic intervention, we may tend to forget these things, which we need to keep in mind, and which we need to ensure that such documents are documented and used in times of crisis situation.
Dr. Ati, I just wanted to add one thing, as Dr. Janardhan said about co-therapist. It shouldn't be within the campus. It can also be where the patient a patient is hailing. If he's been coming from a rural, remote place where the district hospital or a district place where the social workers who has been available, and we also need to have a contact with them, and we should ensure they have undergone this training. They also should be thorough about what we have been discussing, so that it is easy for us to convince or to bring consensus with the patient and client, family members, to sort out the immediate crisis with the nearby co-therapist. So this is one challenge which I had of getting or tapping the co-therapist.
Hand-holding.
Hand-holding, as Dr.
Hand-holding,
Brinda.
yeah. So what Dr. continued to that, I think we need to have a pool of co-therapist or a therapist in the other region also, so that the hand-holding can be provided to them, so that the continued care can be extended. I think that also we need to keep in mind.
Thank you, Dr. Kanmani. I think we're joined in by Dr. Gandhidas, who is the president of the India Network for Professional Social Workers. We welcome Dr. Gandhidas, and we will have his concluding remarks once we end this program. Thank you so much, sir, for joining us today. I will read out the questions in the chat. I think we've got quite a few questions. I'm sorry, we will not be able to take in live questions by unmuting yourself because of lack of time. We hardly have another 20 minutes to close. I'll start with the first question. Dr. Brinda, Dr. Neena Pandey has asked a question. Thank you, Dr. Neena Pandey, for joining us from Delhi School of Social Work. Dr. Neena Pandey has been an active faculty in the prison setting with Tihar Central Prison, and who's also helped a lot of our students from NIMANS to have a facilitator fieldwork in Delhi from Delhi School of Social Work. Dr. Neena Pandey has asked Dr. Brinda, what are the legal implications and the assistance that is provided to your case, as legal implications are extremely important?
Thank you, Arati. The cases which I have presented here, that since the husband again got married to another lady, that she got to know later point of time. So still she has not made up her choice to give a complaint in the police station and take further action. So during the helping process as a therapist, so I have explained to her that what are the legal options she's having, so that she can exercise that, and informations regarding this I have provided to her, and also explained to her that if she wished to take any further action, so that she can seek free legal aid for further help. So that was explained to her, since the the client has to make a decisions what to be done. So that facilitations was done during the process, helping process, and the issues has been taken care, what madam has told. During in the next couple of follow-up sessions, if the client has made a decisions to go for legal help, definitely that will be provided to her.
Thank you so much, Dr. Brinda. Two more questions in relation to the case. I will request you to answer, one by our students and another by Swapna, on one, whether the lady received any support from her family of origin, and second, whether how was she consoled with respect to the extramarital relationship of her husband.
Yeah.
If you could answer.
Uh, regarding that, this support from the family members, during our assessment, that I found that uh, since it was intercaste marriage, uh, they got married in a temple and have been living together as a couple. So the family members are not in touch with her, and the client also doesn't want to seek any help from the family, since there is a lot of stigma attached in the community for her to getting married to the person who belongs to the different community. So she doesn't want to go back to her family to seek any help. And the, 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 the family of origins, especially her parents, her siblings, doesn't know where she is staying. So this is something that when we explored that, we gathered this information. And the client also expressed that she doesn't want to inform about the crisis that she is undergoing the currently, and doesn't want to take their help. So this is something that the the needs that expressed by her. Uh, Apart from that, she had some support from her friends and the neighbors, but the neighbors are unaware of that her husband that got married recently to another lady. Those issues are not disclosed to them. But however, she has some support from the neighbor in terms of offering her emotional aid whenever she undergoes this violent issues at home.
Thank you, Dr. Brinda. I'll move on to the couple of questions for Dr. Janardhan specifically. So one of the questions that were asked were, how do you obtain consent from the couple's side? That is both the couples, would you take in consent from both of them or only one of them totally? How would you take consent? And the second question is, you spoke about role plays. How are you going to manage doing role plays in a tele session? These are the two questions that came in, Dr. Janardhan.
Regard to the consent, particularly the case what I shared here, so we had obtained consent during the intake session, which happened in person. But only when the telepsychiatric social work, like telepsychiatric services one were extended, we had only a consent from the husband when we had tried to fix up an appointment. So verbally, we were able to get the consent. But we have the way out in terms of sending the document to them and asking them to sign and send it back to us. This is something we need to follow. And we need to get consent from both the couple. It's not that when one joint consent, we are going to take from like either of the spouse. So it need to be from both the spouses. So we need to take consent as per the guidelines we need to do. With regard to your second question, in terms of role play, how it can be done. So this is something I tried out in one of the session where there was issue in terms of the communication between the husband and wife, and husband communicated something which the wife was not able to take it the way like it was communicated or pursued in a different way. The same sequence was put as part of a role play in an audio thing where we modified husband way of communication to the wife, so that the wife also were able to understand, and the way husband communicated and how she pursued is something we asked wife to give a feedback to her. So it's possible for us in terms of using role play. Maybe like we need to take a particular communication which has happened recently between the couple, which was misunderstood and pursued in a different way. The same thing can be put back as part of the role play and ask them to how that communication can be better communicated, so that the spouse will be able to understand and reciprocate back rather than pursuing it in a negative way.
There have been questions about the SOP for virtual OPD. I think there are no specific SOP for virtual OPD. From the experiences that we have had at NIMHANS, we do plan to write up a paper to bring that up, and we'll be happy to share with you when it comes out in public domain. Apart from that, people have also asked about the documentation guidelines, which are available in the PSW guidelines. The guidelines are available on the NIMHANS website, which can be freely available. We've also had questions on whether the same can be used in the prison setting, and of course it can be used in the prison setting. Dr. Leena Pandey had asked, and we do have tele consultation services in the Bangalore prison. However, they are not functioning as of now, but it is very feasible to have basic psychosocial support and interventions being provided, or training the prison staff to provide psychosocial services in the prison setting, which can be explored. We will not be answering any questions related to any certification or courses. I think all of them are available on the NIMHANS website. And I just have two questions for Dr. Kanmani, if we can quickly do this before we close. One is they have asked how to reach those who do not have any telephone or internet facility. And second is if any specified skills are required to prevent escalation in a crisis situation or in helpline situations.
Yeah, the second question I'll answer first. Developing skill and learning skill is extremely important in dealing with the psychosocial first aid, because you need to provide in a way where you will not create any acute crisis. That is extremely important. So one need to have crisis intervention, short-term courses which you need to have, which NIMHANS, and I'm starting, I supposed to start in the month of February, but due to COVID situation, I was unable to. So probably you guys can enroll with the advertisement. And I'm sure that other places also, they will be providing crisis intervention, short-term certificate courses. One need to acquire the skill. The first question, what I wanted to say is, when we do a tele psychiatric social work services in the crisis intervention, without any telephone or without anything, how do we get to know first whether there is a crisis which is existing? And in person, if you get to know, I would suggest, as I have told in the challenges, is co-therapist who is available in particular places, who are well trained in this profession, and who also has a knowledge with this guidelines, who also have a certain skills in assisting or doing the session in a long term. So this is what I would like to answer.
Thank you so much, Dr. Kanmani. I think questions on de-addiction services should follow the same protocol as individual, sessions that are done on tele-psychiatric social work. And we've made it very clear that tele-psychiatric social work is not an alternative to in-person sessions, but it is complementary, or it is taken in a pandemic situation such as this. And it should be in tandem or along with in-person sessions. And in case of an emergency and in-person sessions are required, they should be provided. So it is not an alternative. We will close with the questions due to paucity of time, but we're available over email, and you could mail the department for any queries. I now request Professor Gandhidas, who is the president of the India Network of Professional Social Workers, who have supported this initiative right from the beginning. And this initiative is a collaboration with the INPSWA. Thank you so much, sir, for joining us. We would request you to give in your comments on this occasion. Thank you. Yes, sir. We can hear you now because I've just unmuted you. Yeah,
Yeah.
just
Yes, thank you very much. Thank you very much for this long sessions. And nice to see more than 150 people join this particular webinar, which is a good record. Nowadays, 45 to 50 seems to be working out very well, but we have reached more than between 150 to 160. It is oscillating. Nice to see my good friend Sushma Batra on the screen. She is from Delhi School, my very good friend of mine. Want of time, there are quick things. One of the important points that I request all of you is that in this kind of online, how to frame your questions. This is what Janardhan was mentioning quite a bit back, that he reframed the process. Very important, social workers need to know is how to frame your questions. Because if you frame a question, which is just a long process, then you get a round and round. Therefore, it is very important to think and rethink based on client to client basis, how to frame your question. This is the first skill all of us need to learn. And this skill comes through our research, this skill comes through various process, but I learned in my life, you frame your question and wait and you get proper answer. Therefore, framing questions is very important in this process. The second most important, as I listen to a number of people, when this kind of online guidelines and framework are given, first of all the people who would like to adopt this need to internalize the process and the procedures. Where I see a lot of question is that people try to read it verbatim and try to apply that. That will not work out for this. Therefore, all of us need to read, internalize the process and the procedures evolving out of this. This is very important for me as I look at it, because evolving process and procedures are very important way of dealing with case by case, as Brinda was also explaining, various procedures. So once we are able to internalize, this process is good. The third important point is, since all these models also belongs to medical, social, psychological model, so we always base on medical model, especially when we go to a doctor, diagnostic. The earlier days, when I was young, the diagnostic process is by doctor himself. He will go by elimination process, by asking questions. So we felt very communicative. Today, doctors are so busy, the diagnostic process outsourced to diagnostic centers, different super specialty diagnostic centers. So by the time it comes, the doctor takes a few minutes to look at that and goes on. But in our diagnostic process, which is social, psycho, plus today, cultural, plus the abstract level of the cases that we get today. Earlier days, our cases are very different, but today, the cases that come to us is very, very strong in convictions, which are momentary, very strong in their beliefs, which I consider again as a momentary, because of their very abstract understanding of the life and lifestyles and the life situations. And this is what IT sector, whenever people come and discuss with me, this is what the problem I feel strongly. Therefore, as one of the handholding procedures, we must ask the cases to reflect. That means we need to give between your sessions some kind of a short assignment to reflect on. I don't know whether I loud. Some short thing that people must reflect on their own, because you get a lot of educated people who justify their actions by various logical means, which we find it very difficult. But by referring to them certain of the tools that to reflect on. This lockdown period helped me to reflect on three areas, which I would share with you. Number one is wonderful short novels that if we have, I mean, case by case novels and very interesting stories. Because India is full of mythological stories, novels, short stories in every language. It's flooding. People don't read. And many of these novels, short stories, are all based on real life situation, picturized in their own writer's language. There's nothing that he imagines. He captures from the real life and reflects that with a lot of questions. I could give a number of writers that I went through in the last 3-4 months, but all of them capture from real life situations of the poor and the higher class. Therefore, it is very important. Give them, can you read this? Can you come out? So that the interactive process becomes indirect and strengthening your way of approach. This I consider bringing in the nativity of our own self instead of isolating ourselves into the various as a non-entity, but integrating ourselves into cultural entity and integrating them to reflect with our cultural aspects would go a long way in this kind of process. The last important point that I would like to make is each one can develop some SOPs based on their own context. There can be general SOPs. Even in COVID situation, you would realize ICMR guidelines versus state guidelines versus Home Ministry guidelines with the NDMC, National Disaster Management. Under that, what worked ultimately, if you listen to Kerala stories very carefully, what really worked is you were learning at the ground level. You are learning in the context. You are learning with the cases that you deal in a multilateral way. Therefore, it is important. Each one can develop, and NIMANS is doing a hand-holding situation. Therefore, you can check with the SOPs in the context that you are working on, and that way, we will be able to have number of procedures that can be emerged as a very broad spectrum, because our country is a diverse, we deal with a very diverse crowd. Therefore, single SOPs will be a guideline. It will not be a pointer to results. If you want to be a pointer to results, I think we all have to reflect and work out our own SOPs. Check with NIMANS is always giving the guidelines. Therefore, check with the NIMANS whether these SOPs are working, bring certain course corrections, bring certain modalities, and that could emerge. So these are my short and brief comments. Thank you for bringing me into the system. Thank you very much.
Thank you, Professor Gandhidas, for giving in very valuable insights as to how we can make tele-psychiatric social work more effective, especially with providing more cultural examples and by providing them some assignments so that they can reflect over the same and get back. We will close the session today, but I know it's been a huge learning experience for a lot of us through the questions that you've asked, and I'm sure that you would have learned a lot as participants. To conclude the session, I now hand it over to Professor R. Dhanasekaran Pandian, our head of the department, to give in the vote of thanks. Thank you.
Thank you, Dr. Aarti. I personally believe the COVID-19 is a natural experiment, and this pandemic has given a wake-up call for the entire discipline of mental health, like psychiatry, psychology, psychiatric social work, and all the discipline. And already as a mental health professional, we are all well aware, even in the normal situations, there is a huge treatment gap across the world. Grossly, there are many inadequate resources in terms of finance and trained manpower and trained resources. There is a gross neglect of persons with severe mental disorders, even in the normal situations. There is a neglect of vulnerable population. There are many severe economic burden experienced by the people with mental disorders. There is economic slowdown. There is economic and social problems like unemployment, economic decline, loneliness, intimate partner violence, exacerbation of mental disorders, social distancing, addiction related problem, and there are so many impact because of the COVID actually. Now there are many reports are available which talks about the global recession and extreme amount of poverty and long-standing and social economic inequalities among our populations. So as a result, the underprivileged sections of population have always have greater risk for developing various kind of health risk as well as mental health risk. So that's the reason the entire demands, we strongly believe that every challenges we must make it as an opportunity. We must convert as an opportunity. As a part of this work, NIMHANS and the Department of Psychiatric Social Work, we have initiated many programs. To save some of them, one is the continuum of care program for in the lockdown actually. The second program, tele aftercare through telemedicine based kind of services, interactive voice response system through IVRS, and addressing the mental health of migrant workers. And I am also very extremely proud to say the Department of Psychiatric Social Work, through the psychosocial support and mental health services of NIMHANS, we have trained more than 3 lakh people. We have provided services, and we have also indirectly contacted with more than 44,000 cases and calls from all over the country through our member organizations. And but we know the reality, the pandemic will not pass very quickly. It may take some more time as per the reports. So we have to prepare to meet such kind of the challenges, particularly on the mental health consequences of the people who are in need. So we have learned many lessons from this pandemic. We have learned from the past when our professors like Professor I.A. Sharif, Professor Anbir Singh Bhatti, Professor Parsari, Professor Ranganathan, Professor Muralidhar, and when they were providing the services for psychiatric social work, the situation were different. But today, when Professor Segar, Professor Trimurti, and in my entire team, the situation is different. And that's the reason we have to think about the appropriate kind of services. So the department uniformly decided a rapid shift is happening in the field. So we have to make through telehealth, through telemedicine services, and we have to develop the guidelines of telepsychiatric social guidelines. That's what happened today. So there are many innovations and opportunities to provide a meaningful service delivery to the people who are in need through digital mental health care. That's what our department has initiated. So I personally and strongly believe this opportunity, this telemedicine services would be providing a meaningful service to all the people. I also strongly believe that the present guidelines could provide a conceptual framework for professional social workers working for the empowerment of individuals, families, groups, and communities in order to improve their overall quality of life. I sincerely thank our beloved professor, Dr. B.N. Gangadhar, our Director and Vice Chancellor of NIMHANS, for all his support. We sincerely thank all our deans, very especially Dean of Behavioral Sciences. We are extremely thankful to Professor Dr. K. Segar, our Professor of Psychiatric Social Work, and the registrar and the architect of the many services at our institute. I especially thank Professor Gandhidas, President of the India Network of Professional Social Work Association. The entire world is appreciating their credibility for the India Network. And very recently, India became the Vice President of the Asia Pacific regions in the International Federation of Social Workers. And we are extremely grateful to Professor Gandhidas and Dr. Many other members who are actively involved in the India Network. And our special greetings to Mr. M.V. Sri Ganesh, the Secretary General of India Network of Professional Social Work Association, for their collaboration in empowering this initiative from the department. I am especially thankful to Professor A. Tirumurthy Professor of Department of Psychiatric Social Work and Senior Consultant in Geriatric Services, Dr. Janardana, Additional Professor of Psychiatric Social Work, Dr. Vrinda, Associate Professor of Psychiatric Social Work, Dr. Arthi Jagannathan, Associate Professor of Psychiatric Social Work, Dr. Kanmani, Additional Professor of Psychiatric Social Work, and all my colleagues in the department. I once again sincerely thank Dr. Suresh Balamat, the Professor, Department of Psychiatry and Head of Telemedicine Services of NIMHANS for all this technical support. I am extremely grateful to Dr. Surinder Jaswal from Tata Institute of Social Sciences, Professor Sanjay Bhatt, Professor of Department of Psychiatric Social Work and President of the National Association of Professional Social Workers, Dr. Kalpana Sarthi, Deputy Director, Tata Institute of Sciences, Guwahati Campus, Dr. Ramila Segar, Faculty and Dean of Social Sciences, Rosindalia, Professor Ilango, Bharatidasan University, Tamil Nadu, Dr. Anis from the Kerala Association, Dr. Sonia Pereira Diori from LGP Tejpur, Assam, Dr. Subhasis Patra from the Department of Social Central University of Rajasthan, Dr. Praveen Yannavar from IBAS, Mrs. Veeralakshmi Rajsegar from the India Country Consultant from the Children Heart Link, Dr. Nancy Kumar, Medical Social Worker, Jipman Pondicherry, and many other people who are directly and indirectly involved in the process. I am extremely grateful to the guidance always we get from our professors, Professor R. Srinivasa Murthy, for all his support and guidance in the entire process. And even today also he is one among the very, very active participants, and he is consistently providing all the support. I am extremely thankful to Professor R. Srinivasa Murthy, our professor and former head of the department and former dean and senior consultant and editor for the World Health Organization, and still continue to provide these services to the department. I am thankful to Dr. Juva Srilata, Professor of Social Work from Tata Institute of Social Sciences, Dr. Neena Pandey from Delhi School of Social Work, Dr. Neelam Sukramani, and Dr. Grees N. Rao from Department of Epidemiology, Dr. Sangamitra Iyengar, the Director of the Foundation, and Dr. Susma Batra from Delhi School of Social Work, and many other, Dr. Miriam Sambal from Madras School of Christian College, and many other members who have extended their support and give their valuable suggestions for developing this activity and for this today's discussion. I sincerely thank every one of you for your valuable time. With this rich experience, the department will take it forward and we would provide the meaningful service delivery to the people who are in need. I sincerely thank every one of you, very especially Dr. Arthi Jagannathan for wonderfully coordinating the entire process, along with Professor Tirumurthy, the team head of this entire development. I sincerely thank every one of you for this wonderful opportunity. Thank you.
Thank you, sir.
Thank you so much, everybody. We'll now close the session and we'll leave the meeting. Thank you. Have a nice day.